So thank you, Professor Scott, for the introduction, and thank you to the organisers for having me. I'm very humbled to be in the company of the other esteemed presenters in this session, and I look forward to hearing their presentations. So when I set off for my Cardiothoracic Fellowship in mid-2019 at Royal Papworth Hospital, I wasn't expecting to be a frontline worker in the epicentre of a pandemic. Papworth is a 300-bed quaternary cardiothoracic centre performing multiple complex procedures and is an ECMO referral centre, and the entire hospital was transformed into a COVID ICU during the pandemic. And the UK, as is well known, has seen an extremely high number of cases of COVID, with daily deaths close to 1,000 in the first wave in the UK, and with ICU admissions happening at an unprecedented rate. So in regards to my experience at Papworth, it really shifted when we became a surge centre, with initial discussions of us taking up to 200 ICU patients. We created capacity for these extra patients by cancelling elective surgeries where possible and a massive redeployment of all personnel. All hospital activity was funneled through a single clinical decision cell, which was created and which was a central management team for all doctors, senior and junior. And we divided into task-based teams to manage workload, with quite a significant reliance on anaesthesia support for many of these tasks. So anaesthesia played critical roles in intubation teams, trachea and bronch teams, proning teams, vascular access and transfer teams, and they reappropriated people from other disciplines. So physiotherapists became part of the proning team, and ward nurses and junior doctors became bedside ICU nurses. High numbers of our staff underwent risk assessments and needed to shield or were self-isolating due to a contact. So at any one time, we certainly had reduced numbers of staff. So really, this became the new normal. Our entire hospital was a COVID centre, and we had over 65 patients at the peak. The ICU expanded, including 2 out-of-unit pods in our cath lab recovery, and our respiratory ward became a centre for our patients on non-invasive ventilations and with trachees. No visitors were allowed, and social distancing was strictly enforced, with all of our group meetings ended. And here are a couple of things I saw on my way to work when there was a lot of support for the NHS during this time. In regards to PPE and isolation management, because a number of, prior to starting this, we had patients at Papworth who were transferred in with VV ECMO, often with contagious respiratory viruses. All ICU and anaesthesia staff were fit tested upon arrival, and that expanded to the entire team during the pandemic. We had a lot of training on donning and doffing. We had stations that were placed as we entered and as we left anywhere that was a COVID area. We were so fortunate to have enough PPE during this time. We had a reusable check-in and check-out system. So we ensured that everything was cleaned and then reused our reusable masks and visors so that we never ran out while I was there. And I'm not aware of any case of occupationally acquired COVID in our team. We had our entire ICU pods that were COVID positive, so we would don before we walked in, and then between each patient we would change our outer glove, alcohol, rub our hands, and then place new gloves and carry on. And at the peak, our theatre cases were performed in full aerosol protective PPE. Obviously, that's immensely labour intensive and comes with some challenges, and we stepped that down over subsequent weeks. You can see on the right here that I'm wearing one of the PAPAs. I used to take them out where possible for ECMO retrievals, because I found that they were more comfortable for extremely long periods of time, and it was a lot easier to communicate through the clear visor where people could actually see your mouth. And here you can just see the well-circulated CDC poster on facial hairstyles, and there were a lot of faces that hadn't seen the light in years in our hospital. In regards to our theatres and managing airways, we continued all of our most urgent surgeries and helped to perform surgeries that would facilitate discharge for any of our patients. So some of our patients on Centromag BIVADs were transitioned to durable LVAD in order to facilitate discharge home. We continued to perform any urgent surgeries such as aortic dissections or left main disease, and we continued thoracic's cancer surgery, which required full PPE throughout all the months that followed. So that was extremely labour intensive. We developed a MERIT team, which has been used in other centres and other countries, a mobile emergency rapid intubating team. And we had a box that you can see there on the right that we could take to all of our calls, and we would only remove what we needed so the rest stayed uncontaminated and clean for future use. And of course, we had a method for COVID intubations to minimise aerosolization. My particular technique was, where possible, to directly intubate with the endotracheal tube already connected to the HME filter and directly to the ventilator. But where that wasn't possible, I employed a clamping technique and video laryngoscopy. But of course, sometimes the best laid plans can be challenging when you are off the floor and in an emergency. In regards to the ICU care for our patients, the mainstay of care continued to be supportive and just best critical care practice. At the time, there were many trials being initiated, and we were a part of the recovery trial. We also had some novel therapies like cytosorb. However, we continued to provide largely supportive care to most of our patients. We saw in the airways of our patients copious secretions and blood, and there were a lot of blocked tubes. They required, unfortunately, a lot of bronchoscopies, which we performed as carefully as we possibly could in an ICU open environment. Many of the patients had tracheostomies, and nearly 50% of our patients admitted and nearly all of our patients on ECMO. We found the patients were having hypoxemic respiratory failure, and we employed lung protective ventilation and a lot of proning. We did drive initially a negative fluid balance like traditional ARDS treatment. However, we found that there were a lot of secondary effects because these patients were so hyperpyrexial. They had a lot of evaporative losses, and we found that they developed a lot of hypernatremia and pre-renal renal failure. As I said, the patients were quite tachycardic, hyperdynamic, they were anemic, and they were quite prothrombotic in both the venous and arterial systems. So anticoagulation protocols were developed. And they required extremely high levels of sedation. And we had centres that were running out of neuromuscular blockade and propofol. And as also many of these patients required renal replacement therapy and developed secondary infections. So a part of my work during that time was being a part of the ECMO retrieval team. So during April 2020, the National ECMO Service received a mean number of 30 referrals each day, with the highest number received on a single day of 48. And nearly 900 referrals in the month of April, compared to a total of 80 to 90 in the Aprils of the preceding years. And during the peak of both wave 1 and 2, the National ECMO Service supported over 80 patients on ECMO, and PAPWORTH itself had over 20 patients on ECMO during both waves. So there were far too many referrals for the pre-existing model to work, and a new team was required to meet this increasing demand to cover the PAPWORTH Trust area, as shown in the purple here. And so the surgeons teamed with the senior anaesthesia fellows, so myself and two of my colleagues, while separate staff managed referrals from home using an online referral system. That would begin with a referral assessment of candidacy and optimisation with our colleagues at home, and then a decision for ECMO, including multiple intensivists, and then a retrieval team activation. So our team performed over 40 retrievals between March and May. So the development of this interdisciplinary retrieval team was a unique collaboration, as whilst we had all worked together in theatres, we found ourselves in an unfamiliar and in challenging environments together. I had the privilege to work with our Chief of Surgery, Mr. David Jenkins, on a few of the retrievals, and certainly some skilled hands from which to finesse my cannulation technique. There were occasionally up to 10 referrals per day to our team, as you can see from the graph on the right, and usually 2 retrievals, and on one occasion 3 retrievals in a day. So these could take up to 10 to 12 hours at a time. So you can imagine it was a very busy time for us, and quite a lot of work around the clock. So actually arriving at the hospitals where we would perform the cannulations and retrieve the patients was an extremely sobering experience. The district general hospitals with emergency departments, and many of these were in East London, had been the first to see the increase of patients, and it was really the first time I'd seen the ICU so overwhelmed. These were some of the most unwell patients I've ever looked after, and often there was a local team who were not usually caring for patients with such severe illness, and they really did such a phenomenal job in the setting of being quite overwhelmed at times. So I would go and reassess the patient, ensure that they were still an appropriate candidate for ECMO, and then we would take the patient to the local theatres, where we would keep them proned until we had everything ready to go, and then we would turn them supine at the last minute, as inevitably they would desaturate and become hemodynamically unstable, and we had to work very rapidly to cannulate them in order to stabilise. And this picture just demonstrates our usual cannulation technique, which was a right femoral drainage cannula and a right IJ return cannula. We saw over the next period of time that the patients required ECMO for extremely long periods, some 2 to 3 months before they could be decannulated. They had a complete loss of lung compliance with no tidal volumes initially, and we continued to prone, which seemed to help. They certainly had, as I mentioned before, this profound inflammatory response. They were hyperdynamic. A number of the patients we looked after were obese. They were hyperpyrexial, and they really had this extremely high cardiac output state where sometimes our ECMO flows were just inadequate despite pharmacological attempts to reduce cardiac output. And we sometimes had to place second cannulas to help with flows. As I mentioned, we did see people that had PEs, and actually some patients had visually you could see iliac thrombi as we cannulated, as we placed the venous cannulas. And of course, sadly, they unfortunately developed a number of secondary bacterial and fungal infections which required treating as well. But there were some heartwarming stories that came out of this, and we had one person whose partner had delivered twins while he was on ECMO, and he eventually was decannulated and recovered enough to go and be with them. Obviously a long recovery ahead of him, but certainly a really special moment for everybody in the team. So of course, this period of time and this work came with a number of challenges. Working in PPE endlessly is tricky, it's uncomfortable, you can feel yourself becoming hypercapnic, and a number of people develop pressure injuries from the masks because when worn properly, they sit very firmly on your face. We had to get more comfortable with the delay to arriving to urgent situations, so where we had to don before we would go into arrest calls within a COVID pod. And sometimes we had to do remote management as we were on our way. So, for example, as we talk a registrar perhaps from home through starting management, I would talk some of our medical registrars through giving drugs like rocuronium, metaraminol, things they were not familiar with, as I was donning to come in and give them a hand. And then, of course, at the end of these periods, the concentration to doff properly was very difficult, but certainly just so important to ensure that we didn't contaminate ourselves after doing this work all day. And it really can be difficult after long shifts. There was a lot of mental fatigue. So obviously it was just immensely sad caring for so many people that were unwell and knowing what was happening in the community. And that was underpinned with a fear of contracting this illness that at the time we still didn't know that much about. And of course, there was distance from home for many of us. I worked with a lot of international fellows, and significant travel limitations, which unfortunately still remain. Some of the things that really helped to get me through were the collaborative approach and the teamwork that we all shared, and just the absolute commitment from the staff. I think out of anything like this, we have to look for opportunities and ways to sort of learn from it. And I think in the middle of a crisis for the world, it felt meaningful to be able to contribute our skills. There were new collaborations in critical care, as I described, in our ECMO retrieval team, but certainly in the ICU or in the hospital, we would have respiratory registrars, cardiology registrars, anaesthesia and ICU fellows, and surgical fellows all working together, problem solving, sharing each other's skills, and trying to work through how we could best take care of all of these people. I think there's a great role for anaesthetists in helping to care for patients with COVID. We're generalists, we're proceduralists, and all of our intensive care colleagues have been and will continue to be grateful, I'm sure, for any support that we can provide in these circumstances. And as I've said, I was absolutely humbled by the commitment from staff, in particular the nurses who were so short-staffed and continued to just work incredibly hard every single day. And I think out of this, we developed at least some understanding of what at the time was a new illness and experience for further waves and pandemics, and certainly the reduction in mortality in the second wave in the UK and in the world is partly due to improved ICU care and really learning from these experiences that we all had. So life in Cambridge lockdown wasn't all doom and gloom. I think every day at work and being a part of this made you appreciate every day off. And we were so lucky to have an absolutely beautiful spring during the first peak. I spent a lot of time outside, and I was really fortunate to acquire an inflatable kayak that took me up and down the River Cam, which was just a wonderful way to unwind following some of these days. So thank you so much again for the invitation to speak and to share my experience. I'd just like to acknowledge the staff at Royal PAPWORTH Hospital that I worked with, in particular Dr. Alan Bulsteck and Mr. David Jenkins for their mentorship. I'd like to thank Dr. Rachel Juice for sharing further ECMO data with me for this presentation. And of course, my mentors and supports in Melbourne for their endless contact during this period. And every conversation and bit of encouragement made a big difference. I'd also just like to thank my colleagues and friends, known and colleagues not known to me, who continue to selflessly care for people during this pandemic. And if anybody has any questions, please feel free to contact me at my email below. Thank you so much.